what are the types of incisions used for neck dissection? Types of incisions. There are so many incisions, different types of incisions are there. But no single incision or a combination of incision has received universal acceptance. So, how can we decide which incision has to be used? There are so many decision factors. To select the type of incision. First one is personal preference, that is of the surgeon. Okay, so depending upon the experience and the confidence of the surgeon, he can decide which incision has to be used. Then patient factor, that is age and general condition of the patient. Extent of the disease on imaging, that is the site and the size of primary as well as the neck node. Level of lymph node to be accessed. The different levels are there, that is already discussed. Please see the video, the link is in the description box. Then previous surgical scar. If there is a surgical scar, it has to be included along with the incision. So incision varies depending on that. Previous irradiated neck or not, previous radiotherapy. The general principle is that the accepted no, if the neck is not irradiated previously, then either the apron flap, the Gleck-Sorensen incision, or the Y incision or a crial, or Schobinger incision with the vertical limb as a lacy S incision. Okay. And if it is an irradiated neck, the usual teaching is to go for a McFee incision, that is a double horizontal incision. But because of the recent advances, the newer methods of radiotherapy, there is no need of going for a McFee incision. There are so many disadvantages of using a McFee that we will discuss along with the incision. So these are the decision factors to decide which incision has to be used. But whatever the incision, the access to the primary as well as the neck node should be adequate without compromising the blood supply. So, whatever the incision is, the first thing you have to decide or to think that there should be adequate access. Adequate access to the surgical field without compromising the vascularity of the skin flap. So there should be adequate vascularization of the skin flap, and it should protect vital structures like carotid artery. So even if there is need of the sternocleidomastoid is removed, or even if there is prevailing infection occurs, carotid blowout will not happen. So that should protect the vital structures, and it should facilitate the use of reconstructive techniques. If planning along with the surgery, the incision should facilitate that also. And cosmetically appealing scar, that means more of horizontal along the skin crease than vertical incisions, and contemplate the need of post-operative radiotherapy also. So whatever the type of incision you are preferring, these are the aims that the incision should give. Okay, so that should be kept in mind. And regarding the types of incisions for neck dissection, McGregor has classified that into main three headings. One is Hayes-Martin, then McFee, and Triradiate incision and its modifications. And the most commonly used one is an apron flap, that is the Gleck-Sorensen, commonly used Gleck-Sorensen incision. According to McGregor, the incisions are broadly divided into first one Hayes-Martin, second is McFee, and then Triradiate and its modifications, and another type is includes the apron flap. The Hayes-Martin is a very old incision, and in this the important landmarks are the angle of mandible, hyoid bone, then the tip of mastoid, clavicle, and the sternocleidomastoid muscle. Okay, so Hayes-Martin is a double Y incision. Double Y incision. The upper part component or the submandibular component from the mastoid tip to the mental, and the second component or the inverted limb of inverted Y includes the subclavicular area or the supraclavicular area. Okay, so submandibular area and the supraclavicular area, and it is joined by a vertical limb. So this is usually used for functional as well as selective neck dissection. So from this itself you can see more of disadvantages than the advantages. So what are the disadvantages? Because there are so many junctional points, chance of flap necrosis is very high. Even carotid blowout can happen. Secondly, this is cosmetically not at all appealing because this has got a vertical limb. So for all vertical incision there are some disadvantages. One is there is chance of wound contraction, and this the functional capacity of the patient will be reduced because of contraction of the skin of that area. Okay, and also secondly this is perpendicular to the natural skin creases, so ugly scar can happen. So these are the disadvantages and more than the advantages. So hair smarting is not preferred nowadays. So it is a double Y incision. Okay, and if you want the primary is inside the oral cavity, this limb can be extended along the chin. Okay, so the primary can be included along with the neck dissection. That is one advantage of this. Okay, so hair smarted or the double Y incision. Second is McFee. It includes two horizontal limbs. So the upper one will start from the mastoid process, coming up to the hyoid bone, and then again going up towards the chin or the submental triangle. Okay, so that's the upper one, and the lower limb is 2 cm above the clavicle, above this area, and laterally starting from the anterior border of trapezius and coming medially towards the midline, 2 cm above the clavicle. Okay, so it is a bi-horizontal or double horizontal incision. Upper one starting from mastoid process, coming down to the hyoid bone, then going upwards towards the submental area, and the lower one 2 cm above the clavicle, starting laterally from the anterior border of the trapezius muscle, coming medially to the midline. So this has got advantage because there is no crossings or confluences of the incision, so it will not compromise the blood supply at all. And as it is a horizontal incision, horizontally it is very appealing, cosmetically very appealing with very good blood supply, and also the closure of this incision is very easy. It takes very less time, so the time of surgery is reduced. But there are some disadvantages also. The one is there is a bridge flap. See this area. So dissection under this bridge flap is very tedious. So the surgical access is limited, and sometimes the severe bleeding can happen from the under surface of this bridge flap. It is very difficult to tackle also. And then this is very difficult in a short obese patient with a short neck. So first one, the access to the surgical site is less. Secondly, the severe bleeding can happen from the under surface of this bridge flap, which is difficult to tackle and difficult in obese short neck people. And also the fourth disadvantage, this can sometimes interfere with the reconstruction of this area with a pedicle flap. So okay, limited surgical access, bleeding from under surface of the bridge flap, difficult in obese short neck patients, and can interfere with the reconstruction with the pedicle flap. So that is McFee. Is Triradiate incision and its modifications. So Triradiate means from a single point there are 3 incisions are coming and converging on a single point. So the advantage is that it gives a very good access to the surgical field. But disadvantage is delayed wound healing. Because of this confluence, it can interfere with the blood supply to the flap, so there is chance of delayed wound healing and also wound separation. Chance of wound separation is high. So the advantage is very good surgical exposure, field is very well seen, but delayed wound healing and also the chance of wound separation is very high in a triradiate incision. So what are the triradiate incision and its modification? The old triradiate incision is a crile incision. It is Y incision. So the limb start from the mastoid prominence, coming down to the hyoid bone, tip of hyoid bone, and from there it is going superiorly up to the chin or the submental area, and from this at 90 degrees the vertical limb is coming down up to the middle of clavicle. So this is crile incision, and again the advantage I already told you. The advantage is it gives a very good exposure of the surgical field, and this limb can be extended either by a lip splitting incision or up to the chin when the primary is in the oral cavity. And the disadvantage, what are the disadvantages? I already told you, that is, one is chance of carotid blowout is very high, then it is a vertical incision, so like that in a Harris Martin, cosmetical problem with the ugly scar and also wound contracture can happen. So that is why there are so many modifications like lacy S-limb, etc. That I will tell you. So this is classical crile incision. Okay, so I explain the advantages and disadvantages. The second is Schobinger is actually a modification of triradiate incision. Here, like in a crile, this also is a Y incision, but it's more vertical limb is more posterior and lacy S type. Okay, so how it is done? From the mastoid process, it goes to the submental area, and the vertical limb is more posterior. For crile, it was anterior, so there is more chance of carotid blowout. Here, this vertical limb is lacy S-shaped and also it is more posterior. So it is actually 1 finger breadth posterior to the angle of mandible and also perpendicular to the horizontal limb, but it is in a lacy S fashion along the anterior border of trapezius coming to the midline of clavicle. Okay, so this is Schobinger. It's a triradiate incision with starting from the mastoid process, horizontal limb to the submental area, and the vertical limb is 1 finger breadth behind the angle of mandible, perpendicular to the horizontal part in a lacy S fashion along the anterior border of trapezius coming to the ending in the midline of clavicle. Okay, so that is Schobinger. So again, this axis or the surgical exposure is very good, and as it is posterior incision, the chance of it is covering the vital structures, so chance of carotid blowout is less. But the disadvantage is that as it is a vertical incision, the cosmetic deformity or cosmetically bad scar can happen, and also the long anterior, there is a anterior flap is long, so it can compromise with the blood supply. So there is chance of necrosis of the margins of the flap. Okay, so this is Schobinger. Next is a horizontal T or a Hector flap. Hector. This is a new, relatively newer incision. It is horizontal T. So the vertical limb can be it's made more posterior, starting from the mastoid prominence through the anterior border of trapezius coming down to the clavicle, and any vertical limb. In vertical incision, care should be taken. The limb should not cross the clavicle, because if you that may compromise if you plan a future chest flap. So this should be above, should stop above the clavicle only, ideally 2 cm above the clavicle, and the horizontal limb comes from the 90 degrees from the vertical towards the midline below the hyoid bone. Okay, so that is horizontal tip. And another one is a utility flap. Incision is similar to an apron incision, but a little bit different. It also starts from the mastoid process, coming down along the anterior border of trapezius, then anteriorly, then again it rises up, crosses the hyoid bone, reaching up to the submental area, up to the chin. So this is utility incision, is more of a U-shaped. And if the upper extension is not there, it becomes a lateral utility. This is lateral utility, and the vertical limb can be curved a bit also. Okay, so this becomes lateral utility. All these incisions are not crossing the midline. If it is crossing the midline, again there are 4 types of incision which cross to the opposite side. So, chin, nose, patient is lying, and this is the chin of the patient. So, and the neck visor incision, starting from one angle of mandible up to the other angle of mandible, like a visor. Okay. Is extended thyroid incision. That is thyroidectomy incision is extended downwards, crossing the midline to the opposite side. Okay. And the third one is an H incision, that is two vertical limb on either side, starting from the mastoid process downward up to the clavicle, and the horizontal limb connecting the two vertical limb at the level of cricoid cartilage. Okay. See, so that is a H incision, like the two vertical limb and a connecting horizontal limb. And another one is a classical apron flap or the Gluck-Sorensen incision. Most commonly used one is a classical Gluck incision. It's actually apron flap incision, and this is very good for a selective or a functional neck dissection also, if it is combined with or without total or partial laryngectomies. So it starts from the mastoid tip, that is coming down up to the cricoid cartilage, from one mastoid tip to the other mastoid tip, up to crossing over at the level of cricoid cartilage. And if we want posterior extension, the posterolateral vertical limb can be extended. In some cases, to increase the cosmetic appealing, this vertical limb can be avoided, and as such the apron flap can be extended postero-inferiorly also. And if you are doing a total laryngectomy along with this, the midline extent can be extended down to include the tracheostoma for total laryngectomy. And if you are combining this with a partial laryngectomy with a temporary tracheostomy, then this can be done at the cricoid arch itself, and another incision can be done at the second or third tracheal ring to include the tracheostomy, if it is a temporary one. And if it is a permanent tracheostoma of total laryngectomy, this flap can be slightly extended inferiorly to include the tracheostoma. Okay, so this one is Gluck-Sorensen incision or apron flap. This gives a very good exposure to the surgical site, and also cosmetically it is much more better than so many other incisions. Okay, so these are the different types of incisions used for neck dissection.